over the ethics on opioids. The items that we'll be going over today is an introduction of the opioids, discussion of any precedent legal cases or legislation, the discussion of any precedent of medical journal articles, the discussion of at least two opposing views, how the ethical issue impacts healthcare delivery and impacts PA's practice of medicine, how the ethical issue impacts patients, and any recommendations or best practices on how healthcare providers can resolve the ethical dilemma. Introduction to opioids. Opioids are a type of drug that come from and mimic natural substances, opiates, narcotics, and painkillers. These drugs work in the brain in order to produce many effects, with the most commonly being pain relief. These drugs must be given with a prescription form by a medical provider. Drugs like morphine, codeine, oxycodone, hydrocodone, and fentanyl. Side effects include drowsiness, constipation, euphoria, nausea, vomiting, and slow breathing. Opioids can also be used in illegal drugs. These drugs that are included are fentanyl and heroin, among many more. This is done by swallowing the capsule or tablet, inhaling powders, or injecting it straight into your veins. These drugs are consumed by drug users due to its euphoria or high that it produces. A large source of addiction comes from having the drugs prescribed for medical purposes and then using for a long term. 75% of people who become addicted to the street opioids start by taking them as a prescribed opioid.
During the rise of opioids, many different lawsuits have arisen to fight the pharmaceutical companies that were creating and marketing opioids. However, up until 2019, none of these cases had gone to trial. The first trial was Oklahoma versus Johnson & Johnson. During the trial, the state of Oklahoma represented that around 6,000 Oklahomans had died due to opioid overdose, and thousands were still currently struggling with addiction. There was also data that showed that the pharmaceutical reps from Johnson & Johnson had been bombarding Oklahoma physicians and presenting false information in order to persuade the physicians to prescribe more opioids to their patients. In August of 2019, the court ordered that Johnson & Johnson pay millions of dollars for its role in the opioid crisis in the state of Oklahoma. This trial was the first of its kind, and it put blame on the pharmaceutical companies for the rise in opioid use. Previously, no lawsuit had ever made it to trial and had even had the chance to be ruled in favor of the state versus with the pharmaceutical company. This was the first of the trials that made legislative change for prescriptions of opioids and how it is implemented in patients' care plans.
When looking at legal cases that are involved in the opioid epidemic, the one that I'm going to talk about is the McKinsey settlement. In this settlement, McKinsey agreed to pay a settlement of $573 million for the role that this company played in the epidemic. McKinsey also played this role by promoting their drugs and profiting from the overall epidemic. The settlement funds are going to be used to go towards the treatment of opioid use, prevention, and recovery programs. On top of this $573 million settlement that McKinsey agreed to pay, McKinsey also agreed to pay $15 million in order to reimburse costs and expenses of investigators and attorney generals, as well as to establish an online industry document of opioid use. $7 million of the total is to reimburse the state's costs and expenses. This was due to many of the opioid investigations and enforcement activities that took place. Another approximately $7.7 million is used to fund the establishment of an online resource of opioid industry documents. This is for the benefit of the public. There's also the remaining balance that was used to reimburse additional opioid-related costs and expenses of attorney generals. McKinsey also agreed to adopt a strict document retention plan and be able to continue its investigation into allegations that two of its partners tried to destroy documents in response to people investigating them. The company is being required to implement a strict ethics code that all partners have to agree to each year, and it has to stop advising companies on potentially dangerous Schedule 2 and 3 narcotics.
While there is federal legislation regarding opioid prescriptions, a lot of states have the ability to mandate their own laws around the prescription of opioids. One mandate that varies on the state level is the Prescription Drug Monitoring Program. This program began back in 1918 in the state of New York. It was a way for providers to see who was prescribing what medications and how often their patients were picking it up. This program has largely expanded over the years and is now electronic, allowing many healthcare providers to look up the drug monitoring program and access their patients' information regarding the medications they are prescribed, who the prescriber is, and how often the patients are picking up these prescriptions. This allows a provider to see if a patient is already receiving an opioid medication, the last time they picked it up, and if they're exhibiting signs of abuse. Currently, it is mandated in Kentucky, Tennessee, New York, and Ohio that a provider accesses the PDMP before a provider prescribes another prescription of opioids to the patient. While this is not mandated in every state, it is very common practice for a provider to check this database to make sure that they are not overprescribing a medication or allowing someone to abuse an opioid prescription. For example, many patients that have chronic pain are seen by a chronic pain physician. These patients have to sign a pain management contract in which they state that they will not doctor shop, they will not try and receive more medications than what they are prescribed. They also will follow their prescription as they're supposed to. This means that if a patient that has a pain contract comes to the ED and attempts to receive a higher dose or receive more prescription for an opioid, then they are breaking their pain contract. By checking this monitoring program, physicians are allowed to have information that might not have been available to them in the past, but now they can check this information out before they're prescribing a patient another prescription for an opioid. This program can also be given to law enforcement and different pharmacists to make sure that they are in compliance with patients with their prescriptions and make sure that someone is taking medication as they're supposed to. For example, if a child or family member stated that they had a prescription for Oxy, law enforcement or pharmacists could go into the database and see if they actually were prescribed this or if they may be abusing a different family member's prescription.
When looking at the medical journals that I found in relation to the opioid epidemic, the first one I'll talk about is the prescription opioid epidemic. This prescription opioid abuse has increased dramatically in the past 20 years throughout the United States and has begun to spread to other countries as well. On top of this, the United States is also the world's largest consumer of opioids, and these prescriptions that increased from 76 million in 1991 to 219 million in 2011. This increase in opioid-related emergency room visits, treatment admissions, and overdose facilities. There is also an estimated 25 million people that use non-medical pain relievers between 2002 and 2011. Opioids do more than just produce a high for the consumer. They can be used to relieve stress and anxiety from the day-to-day life stressors. Opioid users also have stated that they continue to use these medications in order to prevent the withdrawal that comes with stopping. When looking at opioid users that become addicted, typically this happens and they become addicted so quick that they don't even realize what is happening. The second medical journal that I found was named Opioid Crisis, No Fix to its Social and Economic Determinants. Throughout this article, it stated that opioids are the second most dispensed drug in the United States. The use of these opioids have changed people's perspective on painkillers as well. Since using them, patients don't want to use other painkillers that are less effective because they want the pain to go away. These opioids are such strong medications that they can make the pain go away much easier than over-the-counter medications can. So people have started to stray away from the over-the-counter medications and ask for the opioid medications. Since this is the second most dispensed drug, there's a lot of money economically that is brought in by these users. Over-reliance on these medications throughout the healthcare system shows that it incentivizes quickly and creates simplistic answers to both complex physical and mental health needs. These simplistic measures also cut access to opioids and other medications available. Overall, both of these medical journals that I found show that even though opioids are a harm to the human population and cause many people to become addicted to them, which leads to a higher drug use throughout the United States, there are other economic determinants and social determinants that create issues in not being able to get rid of these medications. One of the opposing views to opioid pain management is that opioids can provide legitimate pain management for patients with conditions such as peripheral nociceptive pain. An example of this includes rheumatoid arthritis, where the source of the pain is at the joints and is more peripheral in the body. This is different compared to centralized pain, where the brain is largely the issue for the pain that the patient is experiencing. An example of centralized pain would include irritable bowel syndrome, fibromyalgia, tension headaches, and others. These patients' pain begins in the brain. It is an issue with how the pain is receiving the stimulus, rather than someone with rheumatoid arthritis, where there is inflammation at the site of the joint that is caused by their immune system. Patients with centralized pain conditions are not good candidates, as the brain can become tolerant to the opioids, making their pain actually worse because they become sensitized to the pain with the opioids. Whereas in rheumatoid arthritis, if it's managed with the appropriate dose, appropriate timing, the patient can receive legitimate pain relief through the use of opioids. There are other cases where patients may benefit from opioid analgesics. This includes trauma patients, burn patients, cancer patients, and also post-operatively. Opioids have been found to help these patients in these situations to manage their pain. While it is not considered to be a long-term plan for these patients, acutely, the opioids can provide relief. The opposing view is that yes, opioids are not necessarily the treatment plan for long-term care and long-term pain management, but it can be the solution in acute short-term situations, such as the ones as described above. The difference is that the management of these opioids needs to be handled differently than in the case of a chronic, long-term patient with chronic pain. Another opposing view is provider autonomy. Critics of opioid therapy and use are concerned about the possible detrimental consequences of prescribing opioids with excessive autonomy. While autonomy is an important part of medical practice, various individuals argue that several factors should be considered. The physician is the final decision maker in the choice to prescribe a restricted drug. This responsibility stems from professional requirements to treat patients effectively and in accordance with established standards of care, violations of which can result in professional punishment, peer review actions, and quality assurance procedures. Several factors that should be considered are clinical autonomy balance, impact on public health, guideline adherence and responsible prescribing, and risk mitigation.
Although clinical autonomy is foundational for healthcare providers to make individualized and patient-centered decisions, it should be balanced with the responsibility to prioritize patient safety and public health. Laws are set in place to help control the unrestricted autonomy in opioid prescribing that may contribute to unintended consequences. The opioid crisis has highlighted the devastation that opioid abuse and addiction have on public health. Critics believe that provider autonomy should be balanced against the larger social impact of opioid prescribing, which contributes to addiction, overdose fatalities, and overall load on healthcare systems. The majority of opioid prescribing regulation has occurred at the state level. However, federal laws impose limits as well. States, for example, have implemented regulations limiting the quantity of opioid that may be administered for an initial course of therapy. Furthermore, before prescribing opioids, clinicians must disclose particular information to patients. Prescription drug monitoring programs, which track the prescription of opioid medicines, are the most frequent intervention utilized in virtually all states. Some critics also argue that unrestrained autonomy has resulted in overprescribing of opioids in some cases. They underline the significance of healthcare practitioners following evidence-based standards to guarantee ethical prescribing practices, particularly in light of the opioid crisis. Finally, unrestricted autonomy recognizes the need of good pain management, but advocates for a more cautious approach to opioid administration. This includes doing extensive risk assessments, closely monitoring opioid-treated patients, and evaluating non-opioid options to reduce the hazards associated with opioid medication. While recognizing provider autonomy, critics emphasize healthcare workers' ethical responsibilities to actively contribute to reducing the danger of opioid addiction. This might include patient education, cautious patient selection for opioid medication, and continual assessment of the trade-off between pain alleviation and possible damage. Overall, rules that are too strict do not allow for those who are in severe chronic pain to receive treatment. The balance of autonomy versus too tight regulation and legislation can make it difficult for physicians to tailor and adapt a care plan that is appropriate or effective for specific patients. Pain management is a fundamental human right, and health systems are required to offer non-discriminatory universal access to pain management services, including the availability of crucial pain medications and the implementation of national pain policies. The ethical concerns surrounding opioids have significant implications for healthcare delivery. The opioid epidemic in and of itself raises issues about overprescribing, addiction, and patient autonomy. This might include balancing pain management and avoiding overprescription, respect for patient autonomy, access to pain management, stigmatization of patients with chronic pain, and misuse prevention. Although opioids are effective painkillers, their side effects necessitate a careful approach in chronic non-cancerous patients. Healthcare practitioners must emphasize the well-being of their patients while limiting the danger of dependency. Finding a happy medium between effective pain management and avoiding overprescribing to patient addiction is a problematic ethical challenge. Respecting patient autonomy entails open talks regarding possible addiction and the exploration of alternative treatment options. Giving autonomous, informed consent involves the following qualities from the patient. 1. Comprehension of facts and implications. 2. Demonstration of insight. 3. Reason and judgment. 4. The ability to make a decision or communicate a preference. And 5. Voluntariness. To reduce discrepancies in opioid prescribing practices, healthcare delivery entails ensuring equitable access to pain management, taking into account criteria such as socioeconomic status, race, and geographic location. The stigmatization of persons with chronic pain who legitimately use opioids for treatment raises ethical considerations. It is critical to address social prejudice and ensure equitable treatment. Implementing methods to identify and minimize usage without unreasonably restricting access is critical. States with robust drug monitoring programs, such as monitoring a higher number of drugs with abuse potential and updating their data at least weekly, saw more significant reductions in deaths than other states with weaker drug monitoring programs. Ethical issues surrounding opioid use influence how PAs approach patient care, pain management, and their role in mitigating the opioid epidemic. Ethical practice requires PAs to offer patients with complete and honest information regarding the possible risks and benefits of opioid medication. In order to obtain informed consent, patients must be educated on the nature of opioids, its adverse effects, and the danger of addiction. Healthcare professionals play a critical role in pushing for and implementing non-opioid pain care solutions. Staying educated on evidence-based, non-pharmacological therapies and supporting their use when appropriate is a part of ethical practice. Another way ethical issues impact PA practice is by causing increased monitoring and prevention of opioid misuse. It is a PA's responsibility to determine if an individual is a candidate for opioid use. Asking questions about the patient's background and any history of opioid use and abuse necessary in preventing misuse. An initial patient assessment can also determine a patient's risk category from low, moderate, and high. Low risk patients may need to only be monitored annually, while as likely moderate risk patients may be monitored more frequently, around every 6 months. Frequent urine drug testing may also be used, and a PA specialist may be involved in a patient's care. A high-risk patient with one or multiple risk factors of opioid abuse is monitored weekly or monthly, and addiction specialists are likely to be involved in their care. Collaborating with other specialties is expected, especially in dealing with patients who are at low risk for addiction. Balancing pain management has also changed due to opioid use. Patients with chronic illness may have severe pain, but they need to be managed using multiple techniques. Although opioid use was widespread in the past, PAs and other providers must change the frequency of opioid prescriptions by recommending other methods to balance pain management. Management can be pharmacological or non-pharmacological. Common pharmacological treatments are sodium channel blockers and alpha-2 adrenal receptor antagonists. Providers can recommend treatments like acupuncture or physical therapy if a patient wants a non-pharmacological approach. Ethical issues related to opioids have significant impacts on patients overall, influencing various aspects of their healthcare experience and well-being. Informed medical decision-making occurs when patients understand the illnesses affecting them and implications of the related clinical care, including benefits, harms, barriers, alternative treatments, and the certainty of those treatments. For chronic pain specifically, patients need to understand the reason for the chronic pain and ways to relieve the pain. If a patient has mentioned opioid use for the chronic pain, the provider must give information about the adverse effects of opioid use and other options for pain management. The study stated that the average person with chronic long-term severe pain or an 80% reduction in pain when taking opioids. Other options for chronic pain relief are the opioids for physical therapy, antibiotics, acupuncture, and even surgery. The pain specialist may need to get involved if the pain needs to be uncovered. And one is also being determined by the patient may take. Whether impact is balancing pain relief and risk mitigation. If opioids are considered for chronic pain management, the patients understand ways to limit risks while having pain relief from symptoms. Common illnesses for which opioids are prescribed are back pain, arthritis, neuropathic pain, and cancer. The patient may want to use opioids because it is a rapid way to address pain and helps relieve pain more quickly than other alternative treatments. But there is a risk of issues like addiction or overdose. To limit risks, a patient may be involved in opioid treatment agreements. This agreement was reported as a tool in clinical management of chronic pain. The agreement describes the responsibilities of the patient and the provider and the grounds for discontinuing or continuing the opioid treatment based on the ratio of risk and benefit. Opioid treatment agreements may not always be used due to the possible limited health literacy of patients and the worry of further stigmatizing pain patients. Another point is access to adequate pain relief. Patients with chronic pain may have issues finding relief, so that opioid use may be an option. A few chronic issues where opioid use is strongly promoted are patients with cancer or those in end-of-life care. There are positive results for opioids use in oncology and palliative care, and it was considered a breakthrough treatment. Due to the popularity of this treatment, fast-acting opioid preparations like intermediate products were made. Stigma and access to addiction treatment have significantly impacted patients. There is a stigma around opioid use and addiction, especially from the public. This issue is a barrier to overcoming the opioid crisis and for individuals to gain access to addiction treatment. It is found that 78% of Americans, or people addicted to opioids, have themselves to blame for the problem, and 72% believe addiction is due to a lack of discipline. It is noted that people in America distance themselves from people with opioid addiction, and stigma is likely why addiction treatment was previously not a standard. Many treatments are effective, like methadone and naltrexone, which have consistently saved lives. Informing individuals of addiction causes, effective treatments, and using person-centered language are a few things that can be done to reduce stigma and increase access to addiction treatment. Decisions about opioid usage also affect patient safety. Different opioid regulations are present depending on what area a person lives in, and opioids may be more accessible in some areas compared to others. Keeping providers and patients informed about safe pain management practices keeps patients safe despite regulation changes. Under some conditions, the appropriate therapeutic use of prescription opioids can be an effective tool for pain treatment. The biggest source of ongoing worry is the long-term use of opioids to treat chronic non-cancer pain. There is regulations related to lawful access and responsible clinical decision-making. The basis in ensuring opioid-related homes and rating the patient's acceptable therapeutic reasons and access to these treatments. Strategies for addressing the opioid epidemic are usually execute opioids, implementing and prescribing practices, reducing the demand of opioids, and reducing the harm of taking opioids. Several strategies have been used to reduce the opioid demand. Regulating the approved product, example, abuse-approved formulations, restricting lawful access by preventing and penalizing diversion, drug take-back programs, and other state and local policies restricting access. Other strategies influencing prescribing practices. This can be done by providing education, prescribing guidelines, electronic medical records and decision support, insurance policies, and prescription drug monitoring programs. Another way to resolve the problem is by reducing harmful consequences, providing more access and using naloxone to reverse overdoses, and reducing disease transmission, providing options for syringe exchange, supervised injection facilities, drug checking, and behavioral interventions.
And here are our sources. Thank you.